Attending this morning. We're starting a little late as people are still coming in. I'll forego the pleasantries and shorten the introductions as much as possible to catch up with the talks. Our session is on the critical care, cardiac critical care and critical care ultrasound. And I am moderating with Dr. Moza next to me. And our first speaker is Vin Pellegrino, who will speak on innovative management of the failing right ventricle. Vin is an intensivist from my hometown in Melbourne. So it's probably why they got me to moderate. He's very well known in town as one of the go-to person for all things cardiac and ECMO. And I'm sure you'll find his bio in the provided publications. So I won't take up time, and I'll just let him speak, as is always extremely valuable. Thanks, Vin.
Thank you, David, for a very kind introduction. Thank you again to the organisers for the invitation, and thank you all for turning up early on the third day morning. So we're going to talk about management of the right heart, the conditions that contribute to the problems we face, often in ICU, in patients who develop right ventricular failure, and it's commonly a problem associated with afterload. And so we're going to talk a little about the measurement, the management, and the implications of different therapy on afterload in the pulmonary circulation. In terms of disclosures, I have pretty much built my career around doing ECMO. I'm still employed half-time as a clinical lead for a statewide ECMO program, which coordinates ECMO care amongst all the hospitals that provide ECMO in the state of Victoria. And I've worked as a senior intensivist, so I couldn't be more interested and focused on ECMO, and I think that's my main conflict of interest in here, and so we'll talk a bit about that. But in talking about right ventricular failure and the need for mechanical support, that's probably a good thing, right? Involved in a lot of research trials with a lot of excellent research coordinators that attract funding, and I have received small honoraria in the past. So let's start. So what we're going to talk about is the clinical challenge, briefly, about what we see in the ICU setting of patients with presenting with acute and chronic forms of right ventricular failure, and often in the setting of high afterload. The relevant patient groups, support options, a bit of physiology regarding the area, and some possible paradoxical effects to be careful with VPA forms of support. And this may be a new concept for you. It's a relatively new concept, I believe, so we'll see if that gains any traction, and then possibly an approach at the end. So when we talk about the clinical challenge, there are a number of ways patients present to us with right ventricular failure. Often it's associated with disease of the lungs or primary disease of the pulmonary vasculature, and it can be thromboembolic or inflammatory in nature. As well as that, the right heart can fail of its own lack of perfusion. Right ventricular infarcts can be problematic, but they're far less common than left ventricular infarcts. And once you have mediators and impedance on the right ventricle, untrained right ventricle, the normal right ventricle, is not very good at dealing with increased afterload. It's not built like the left ventricle, and it relies a lot on the left ventricle to manage in those circumstances. And that can lead to a spiral, because the perfusion of the right ventricle, once that goes down, everything can happen very quickly. And many of you will be aware of the sudden demise of patients with right ventricular failure around times of intubation, initiation of mechanical ventilation. And these are the common problems we see. This is just an interesting slide that talks about the interventricular dependence of the right ventricle. So what I mean by that is how much the right ventricle depends on the interventricular septum being held strong and tight by the left ventricle when it contracts. If you lose that ventricular wall tension, the right ventricle can generate very little pressure. And so what this shows is the maximum pressure. So the graph on the left, I'm sorry, my laser's not working. But the graph on the left shows the maximum pressure that can be generated by the right ventricle in an animal study when the pulmonary artery is compressed. So they take a heart that's beating and start compressing the pulmonary artery and see how high the pressure in the right atrium can go, the right ventricle can go. And basically it'll mirror what is present in the arterial blood pressure. And so if the left side can generate a high blood pressure, the right side can generate a high blood pressure. That's the graph on the left. On the right, it shows the effect of opening the pericardium and where we start to lose that interdependence, the help from the left ventricle for the right ventricle. And that's probably enough on that topic. So that's a very important factor. In terms of the clinical challenge, there are lots of mediators of lung disease and pulmonary hypertension that can drive changes in the pulmonary vasculature over time. And over time, we see progressively vasoconstriction and narrowing of vessels, and then ultimately the formation of these plexiform lesions that are affiliated with chronic pulmonary hypertension changes and diseases that cause that. And so in terms of the patient groups we have a long list of chronic pulmonary arterial hypertension categories, 1 to 5, that have been there for a long time and haven't changed much. But these are the settings I'd like to say, I think we focus on in ICU, is following lung transplantation in patients with pulmonary hypertension. So these days I work at a large lung transplant centre. We do over 100 cases a year, and most of them have pulmonary hypertension. And most of them need some mechanical right ventricular support to come off. Post-left ventricular assist device insertion, so patients who get chronic heart failure, usually it's left-sided heart failure. They go to theatre and they have a pump put in across the left side of their heart, which immediately empties out the left side of the heart and reduces the amount of tension that you can have on the interventricular wall, and that reduces the amount the right ventricle can work. And one of the common problems is you've got no shortage of power on the left side because you've got a pump, but the right side can't keep up because now it's lost its helper in the interventricular septum, and its ability to generate pressure against inflammatory-induced changes in pulmonary impedance goes down. So that's a really common situation, and we see a lot of that. Primary graft dysfunction after heart transplant is really common. It's a right heart failure syndrome. Mitral valve disease, who have mitral valve repair, mitral valve surgery, that come to us with a heart failure syndrome caused by mitral valve disease. These patients are absolutely classical for getting post-operative pulmonary hypertension. As with patients who have long-standing left heart failure from diseased left ventricles that develop secondary pulmonary hypertension, one of the classes in that list. And if they have surgery or other interventions, that's another group. Major aortic surgery, such as aortic dissections, aortic arch replacements or repairs, and CTEPH surgery can all be associated with it. As well, there are patients who can present with chronic pulmonary hypertension. We're a pulmonary hypertension centre, and we often have patients that arrive either at risk, so they have an intercurrent problem, they might need abdominal surgery or some other problem, and they've got severe controlled pulmonary hypertension. You have patients who become unstable and with an intercurrent illness or a progression of the disease, and then you have patients that are failing, and there's very little time to respond once patients are failing. And then the last group is, the last two groups, acute PE, which I think is obvious and we don't need to talk much about, a large obstructing, inflammatory causing clot in the pulmonary circulation will increase how hard the right heart has to pump against it and will cause acute right heart failure, and that can spiral very quickly and need mechanical support. And ARDS is an interesting one because right heart failure in ARDS is a well-known association. It portends a worse outcome. It's not necessarily always understood. We tend to assess the severity and the risk of mortality by PA ratios primarily, or ventilation ratios, but the failure of the right heart is a very important prognostic indicator in ARDS in subgroup of patients, and it does occur in a not well understood part of V support of ARDS. So that's the group, that's where we see these problems, and now we can talk a little bit about what we might do. In terms of options we have at our disposal, if patients can't breathe, ventilatory support is always there, but we have to be mindful of exacerbating right ventricular failure when we institute positive pressure ventilation in people with failing right ventricles. Inodilators and vasopressors are an extremely important part, and it really falls into two categories. People who are naive, who have never had treatment of pulmonary hypertension, might have quite significant beneficial effects when you start the therapy. And people who have been on it for a long time who are failing, obviously addition of further pulmonary vasodilators doesn't usually help. once the right heart fails, it's usually not particularly responsive to inotropes, particularly in the chronic setting. So patients with chronic right heart failure who begin to fail, the addition of inotropes only buys you a short amount of time, not a large amount of time. And so it really does become quite important that in patients that don't respond in those groups to have mechanical supports. And the two mechanical supports that are most commonly used, there are other approaches, there's always other approaches, but the main two are VA ECMO, which I'd like to talk a little bit about because I think it's the most important addition to these right heart failure syndromes that we've had for a long time. So being able to rapidly and in a timely way institute VA ECMO can definitely be life-saving in a lot of these patients and scenarios, as well as VPA support. So that's where you take the blood from the large veins, the vena cava or the right atrium, and you return the blood to the pulmonary artery. You can either do it with an oxygenator in your system, which would be VPA ECMO, or you can do it as a temporary medium-term support with VPA, VAD type configuration without the oxygenator. If you allow me just to go into teaching mode for 1 second for VA ECMO. So most of the blood lives in the systemic veins, about 2/3 of your blood lives there, and that's the large chamber you can see on the diagram on the left. Above you have the right atrium, right ventricle feeding into the lungs, and then you have how ECMO is configured in the system. It takes blood from the venous circulation and imparts it in there. Now, when you use this for right ventricular failure, it has a lot of advantages because all the problems of left ventricular distension that you have with left ventricular syndromes, you do not have with right heart syndromes. It is much easier to provide VA ECMO to patients with right heart failure than it is to patients with left heart failure. And so this is one of the benefits of the support. The other thing to say is not all VA ECMO is the same. It makes a huge difference. It's a life and death difference in many cases about how VA ECMO is configured. And by configured, I mean how it's put in and connected to the patients. And so we've got two examples, one a patient sent to us and one a patient we cannulated. And here we have, on the left is the way we think it should be done. It provides much more ability for nurses to look after the patient, turn the patient, sit the patient up, extubate the patient, and even ambulate the patient, because we have a properly sited access cannula. So that's the one on the left, where the tip is right up, and particularly if you're using a multi-stage hole, the first hole is up near the right ventricle, right atrium. And then you have contralateral cannulation and distal perfusion for the leg protection on the other side. And the reason we want contralateral cannulation is it allows all the blood that's coming down our distal perfusion catheter in the leg to escape again. If you block that side with a big venous cannula, you can much more likely to get leg complications and leg issues. And so when someone brings a patient, yeah, we've put them on ECMO, here you go, just imagine you're the nurse looking after the patient on the left. I might be obscuring the view, I'm sorry if I am. This is a low access cannula. Flows will be difficult to maintain in an awake patient who might be coughing, standing, or trying to ambulate. The securing of the devices is not safe. There's a wide gaping aperture where bugs will get in and bleeding will be common. And there's a very tenuous distal perfusion cannula that would be barely in the vessel up above. And so looking after that patient and recovering that patient is nothing like doing that. And once this is done, it's hard to get back to this point. So I just make that. So the commonest group that we are called to rescue with VA ECMO is the pulmonary artery hypertension group that has a decompensation, because there is nothing else that will work in that context. So if you have a treated patient on therapy for pulmonary artery hypertension who starts to develop transient problems or progressive problems with their circulation, you are on very thin ice, and it's only a very short amount of time you have before that patient is beyond our help. And so initiating VA ECMO. And it's been a very successful group of resuscitations in that group. It is generally just a bridge to transplant. So these are patients who are selected with pulmonary hypertension or who are completely well patients who present for the first time with very severe pulmonary artery hypertension. It works brilliantly for most patients. Patients are awake often for the entire time, even during cannulation, and they stay on it for the whole time. It's well tolerated, it's quite quick to insert, depending on the skill of the operator, and I'll talk about the main challenge of cannulating these people, it facilitates intubation. So if there are bronchial bleeds or bronchial artery hemorrhages that need to be treated, and we need an airway to do that, we can do that. If there's other surgical procedures, we can provide an airway to allow for those to happen. But we can generally avoid mechanical ventilation once we've got these people on if there's not another reason for the tube. The really important thing is this is a terrible group to do for post-cardiac arrest. So if you've got a patient with known pulmonary hypertension who has actually arrested, they are a terrible group for eCPR, in-hospital eCPR, because you can get them on, circulation will bounce straight back, but the brain is usually irrevocably damaged during that time. The main challenge, this is one of these patients, is you can see this very underdeveloped peripheral arterial circulation that develops in people with pulmonary hypertension. So they've been getting by parsimoniously on a tiny bit of cardiac output support, and their arteries seem to notice over the years and taper down. So this is a superficial femoral artery in an adult at 4.8 millimetres. So very small targets for peripheral VA ECMO can be hard to cannulate. But if the interventionist can do it, we can definitely do it, is what I would normally say. Okay, there are some circumstances where I think where VPA ECMO is actually possibly beneficial. And I think the clearest one of these is in the group that's had an LVAD insertion. So VPA would be absolutely standard therapy rather than VA ECMO. So if you've had a patient with very severe heart failure who's gone for their LVAD and their circulation fails, supporting the right ventricle mechanically is the next step. And doing that with VA ECMO would be a complete disaster because you would bypass your new pump, there would be not much blood through it, and the risk of thrombosis would be very high. So providing VPA ECMO would be the way to go in that. And by the same token, patients who develop circulatory failure refractory to inotropes and supportive care after mitral valve replacement or repairs run the same risk if you provide VA ECMO, in that you bypass that part of the circulation and clotting is more common. And one of the problems in lung transplant is that you lose the bronchial circulation. So once the bronchial circulation is gone in the new set of lungs, lung ischemia is quite a possibility to occur. And so VPA could be a possible use in there. We generally don't do it because we like to maintain the pulmonary blood flow. And we know how to do it with VA ECMO, but it would make sense to do it in that. So physiologically, that's the place to go. I'd like to just talk a little bit about afterload, just check how we're going. So we've got about 5 minutes?
We've got
Three, okay. So the most important thing to say about about afterload is if you could remember this picture in this scenario. So we often talk about the PVR or the SVR, or even index them as evidence of how hard the right ventricle needs to work. The problem, the way I would look at that is that's like saying the resistance to pulling that sled behind a snowmobile or a tractor would be the PVR or the SVR number. It's what happens when you have constant pull on the system and you're not starting and stopping. The actual impedance, or how hard it is to push against it, has a lot of difficulty, as the mother would have, in pulling these kids with inertiance. So every step, the system stops and has to restart. And that isn't taken into account when we use PVR or SVR numbers. So the best thing we could do for this lady is provide her with a long, stretchy rope, which would mean that the force she puts into her walking would be transmitted more smoothly, and you wouldn't have all those impedance factors from inertia, from starting and stopping. If you want to measure how hard it is to push, you actually need to measure simultaneously the flow and the pressure in the vessel and then analyse accordingly. It's mathematical, it's very complex, and this is what it looks like. So the impedance graphs are on the left, and you can see the difference in impedance effects with nitric oxide versus dobutamine. Both of them reduce PVR, but only one of them reduces impedance, making it easy in the early frequency spectra, which are the heart rate. So we normally deal with about 1 to 2 hertz. So in that range. So you can see they're very different, and PVR is not a substitute for actual impedance. And so we often use long stretchy elements to get over inertiance problems. So in my remaining time, I was just going to talk about the measures of systolic function, which I think we might have to skip for the purposes of this, which are given by the end-systolic pressure-volume relationship. And what I'd like to talk more about is the EA ratio. And the EA ratio tells the story of how much impedance there is. So it's much easier to measure this than it is to measure the flow and the pressure instantaneously and analyse. Because all you need to know is the start of the ventricular systole. So if you look at the bottom right dot on the blue curve, that's the start of systole. It comes up and then the blood ejects. The aortic valve closes at the second dot, and so that's the systolic phase. Everything about the difficulty of pushing blood out is described by that movement. So the gradient between the start and the end gives you the impedance of the ventricle, and that's very important. I think my time's up.
Thank you.
I'm very happy to stop there and see if there's any questions later on. Thank you.
Thank you very much, Vin. We'll have the questions at the end, so if you please write them down. Vin is one of the go-to people for very complex cardiac problems in my state, and we'll go from my state of Victoria to the state of Queensland. Another person who is the go-to person for that state, Kieran. Kieran is probably very well known here, but he's a senior specialist and director of research at Prince Charles in Queensland, as well as hosts multiple high professorial appointments at the university as well. The most important thing is his passions is about ECLS outcomes through innovation, research, and education, and addressing the global variabilities of care delivery. Thank you very much.
Thanks, David, and morning all. So my topic today is using extracorporeal life support in toxidromes. It's an interesting topic because, of course, ECLS can be used in a variety of patients with cardiorespiratory failure, and nothing is more spectacular to make a heart fail acutely than a good dose of something. Sometimes you don't know what it is, but clearly I don't have any conflict, especially in relation to this talk. So it's a problem. Sadly, I think the burden's gone up, probably after the pandemic as well. There's a lot more poisonings, accidental, intentional happening around the world. Obviously, we don't have global data on what is the actual burden and how many actually end up in intensive care. But roughly in US alone, the poison centers there record around 2 million cases of poisoning with a couple of thousand patients dying. And as expected, most of the medications are either abuse of analgesics and opioid drugs, and then ingestion of cardiovascular medications. Street drugs are on the top of the list as well. Very obvious. That's probably the trend in most countries. Based on their data, around 140 cases, they used ECMO. Clinically, the toxins typically manifest as profound shock and some cases cardiac arrest, and then many of them aspirate or for other reasons may develop severe lung injury and acute respiratory failure. It's important to remember sometimes we get patients, especially who had street drugs with severe sympathomimetic kind of overdose with tachycardia-related cardiomyopathies, and some drugs can give hypersensitivity reactions and myocarditis leading to heart failure. And sometimes shock can also be due to just mitochondrial dysfunction, more at a cellular tissue level, especially with some of those pesticides. Aluminum phosphide is probably one of the common ones. We see in a couple of those. Essentially, it doesn't matter what you ingested, and when you're talking about extracorporeal respiratory support, it essentially comes down to the heart and lung not doing enough to deliver enough oxygen to tissues. And all we do in intensive care is to try and optimize oxygen delivery. That's our job description. So whether we use drugs, pharmacological support, or mechanical support, in the end doesn't matter as long as we get the job done. So clearly, when this is the problem as a result of toxin ingestion in this particular context, all we need is then, we try and support the patient pharmacologically, and if that doesn't work, Clearly, extracorporeal life support should be strongly considered. I'll tell you why in a minute. And most of you are probably familiar with ECMO, and Vin took us through some of the basics. So it's draining venous blood and returning oxygenated, decarboxylated blood into the arteries to provide mechanical circulatory support. And the rationale for that is to improve the delivery oxygen and consumption of oxygen ratio in situations where there is severe cardiorespiratory failure. These are all the fundamentals of ECMO. We know arterial ECMO, Vin did mention just then, venous drainage using a large cannula and returning retrograde into the distal aorta. That should provide sufficient mechanical cardiac circulatory support to get through a crisis. And these are the poisons in case you have them at home, be careful. So most of them are pharmacological agents, of course, in toxic doses they can be dangerous. I'm not going to read through the list, but some of them are common suspects. Calcium channel blockers, beta blockers are one of the most common poisonings we see. And it could be anything for that matter. Often you don't know what the drug is. The patient just has severe cardiorespiratory failure. And in a crisis, we wouldn't have the time to go and figure that out anyway. So we just deal with the situation based on other factors, including patient age and comorbidities that often play a big part. So these are some of the cardiotoxins. These are some pesticides. I think in some parts of the world, organophosphates and carbamates are still a big problem, especially I come from the Asian countries, so we see a lot of that. Paraquat is an interesting poison, often seen. I think aluminum phosphide is another very fulminant poisoning where ACLS can have a role. These are some other plant toxins, and there is carbon monoxide in some parts of the world, which is seen still. Obviously, this is not a common use for extracorporeal life support, so we wouldn't have a randomized controlled trial on this topic. But what we have is a lot of case reports and case series and some prospective data. I'll just quickly show you what they are. As I said, there's only a couple of prospective case series. Based on that, I don't think we need any specific indication for extracorporeal support. As I said, if you can't deliver enough oxygen to tissues, which are roughly indicated by persistent shock despite pharmacological support, systolic less than 80, 90. I think it's no one number, it's just the whole overall circulation assessment we do, and elevated lactate. These are all the common themes we see when initiating mechanical circulatory support especially. Contraindications, like with any other ECLS runs, pre-existing significant terminal comorbidities are obviously a big no-no. Or if they have severe irreversible organ damage, that's an absolute contraindication. Relative could be some degree of coagulopathy, because some of the toxins at least can give a degree of coagulopathy, and if it's uncorrectable, and that can become a relative contraindication. But when people have gone and done extracorporeal life support, I think these are the couple of key points I would want to make is the outcomes are pretty good. And if you're looking for a good indication for extracorporeal life support in a selected patient with good outcomes, toxin ingestion could be one good group after myocarditis and pulmonary embolism for that matter. So, as you can see, this is data from Experience Center putting it together based on their own experience and then the other sources. So if a patient with toxin ingestion gets to a non-ECMO center, they have a far worse outcome, whether they get in with cardiogenic shock or whether they get in with cardiac arrest. Clearly, you don't need a large data set, but within that small data set from a good center, established ECMO center, we can easily see if they have good pathways. Some hospitals have shock teams, and whatever works for you in your center, if you have good established pathways and processes and access to extracorporeal life support, this is a good group of patient. Especially if you select them well, one could expect good outcomes. This is also 10-year survival survival over a 10-year period, comparing non-poisoned and poisoned patients, and clearly the patients who have a toxin ingestion tend to do well because they have a potentially reversible cause. But when you're doing mechanical circulatory support or extracorporeal life support for any other indication, like acute myocardial infarction, clearly the reversibility of the problem is often under question and the outcomes may not be as good. So whichever way you look at it, the poisoned patients tend to have a better outcome, and that also holds good from a functional survival point of view. If you put them on ECLS at the right time and select the patients well, one could also expect good neurological survival as well. There are some unique features to these patients, and I'm sure in your practice, whether you put them on extracorporeal life support or not, in ICU, typically when we see a person with toxin ingestion, they have a few unique features about them. They are usually younger, they have fewer comorbidities. Even if we went ahead and put them on ECMO, the run is going to be quick. Sometimes I'll put someone on, we had to take them off in few hours' time because there was no need to stay on ECMO and expose them to the risks of ECMO. All we did was put them on ECMO, dialyze them, and the run lasted a few hours. And then we could take them off ECMO. And it also allows time to fix the underlying problem. Often it could be other extracorporeal therapies like dialysis. And for many drugs, as we know, if you know what the toxin is, there may be an antidote also which you can use to stabilize the situation. And often it's the time to just allow the body to metabolize and get rid of the toxins. This is a couple of things we need to remember because there are thousands of poisons. Often we don't know what they are. So it's good to know when not to do it. I think we should definitely do it if you know what it is, or sometimes don't know what it is, but if the patient's young with no comorbidities, definitely it's a good group to do it. But it's good to also know when not to do it. And irreversible organ damage, it's often hard to establish how much is shock-related multi-organ dysfunction or primarily drug-induced multi-organ insult. But if you know the toxin and if it's irreversible, and like these are all very rare situations. I think caustic ingestion maybe you can see, but mercury, I've never seen one. Hope we don't see radioisotopes. But if it's an irreversible single organ damage, that need not necessarily be a contraindication, because if it's especially an organ that can be transplanted, it could be a bridge to transplantation, notwithstanding all the social and other issues that come with this patient profile. Of course, if there is a cellular level failure, then putting them on extracorporeal life support is not going to solve the problem. So in those situations, probably it's not indicated. Same with severe vasoplegic syndromes. If the primary problem is vasoplegia and not severe pump failure, like in septic shock, if it's predominantly vasoplegic shock, they may not benefit. Severe coagulopathy goes without saying for all the ECLS indications. And obviously, once again, there are certain poisons where it's nothing to do with the pump. It's often to do with the hemoglobin oxygen carrying capacity. If that is the problem, then once again, going on ECLS is not going to help. Duration of toxicity, if it's a chronic exposure and it's known, and once again, very rare to find a patient like that, but clearly it's there as a contraindication in a way. And then if there is no effective antidote, but once again, that may not be the be-all, end-all. Often they need supportive treatment. So it's once again a case-by-case assessment. So obviously, this is not an exhaustive topic to give you a lot of information because the literature itself is pretty limited. All I could say in summary is that ECLS should be considered in any case of reversible severe cardiorespiratory failure, in highly selected patients, preferably in younger patients with fewer comorbidities. That's kind of a rule for all ECLS practice. But in this group, as I said, we can be a lot more proactive. I think that's the impression we get is often there is a hesitancy to put these patients on. This is a group with good outcomes if you select carefully, so we shouldn't be hesitant. VV ECMO rarely, like its predominant use in toxic syndromes is mechanical circulatory support because the most catastrophic manifestation is severe cardiovascular collapse. Occasionally, the patient with severe respiratory failure, and then once again, they are a good group for VV ECMO, and clearly the data is really scarce. We need more data. And what is also seen is a lot of I was preparing for this talk, I was myself surprised how many toxicology experts recommend ECMO. And there is a lot of awareness, even in the toxicology circles and other specialties, about the availability of ECLS, and they too are recommending that use proactively, which is good to know. And the true utility will need prospective studies, and these are areas where we'll never have RCTs to guide us, and it'll be always a case-by-case assessment using the basics as we discussed. I think one important thing is reporting to ELSO registry. I think if we don't do that, we'll not have data. And maybe if everyone reports the use, in coming times, there'll be a substantial number of patients we can look at and learn something from. So with that, I'll just encourage everyone to report to ELSO if you're not already doing it, and I finish my talk. Thank you.
Thank you, Dr. Karim, for the enlightening talk. It's my pleasure now to introduce one of my best friends and mentor, Dr. Ghislaine Dauphlé. She is one of the staff in Toronto General Hospital. Her main interest is actually in education and teaching about ECHO and ACLS. The floor is yours, Ghislaine.
Thank you, Moza. I hope the videos will play. Wish me good luck. So, good morning, everyone. I still do not have any disclosures nor conflicts of interest. Still the same disclaimer. For those who don't know how to pronounce my name, it's Dr. Dauphlé, as in soufflé, with a D and one F. And I do not have any shares with any duffel bags company. So in the next 20 minutes, I will talk about the role of echocardiography for patients on ECMO for circulatory failure and describe some common pitfalls and challenges. So the first thing is, obviously, when your patient requires VA ECMO, we assume that they would have had a thorough cardiac assessment, maybe not as much in the case of ECPR, but otherwise you would have assessed the cardiac function. But the role of echocardiography for those patients are going to make sure that you do not have any contraindication, such as aortic dissection or aortic insufficiency or severe atheromatous disease. In terms of the indications, I'm not going to go through all of them, but I just want to mention the patients who have ARDS and acute right ventricular failure, and I insist on acute right ventricular failure. Those patients at the early phase probably will benefit more from veno-venous ECMO or venopulmonary artery ECMO, because we know that once you put them on VV ECMO, you will have an improvement of your oxygenation, of your CO2 clearance, of your acidosis, and your right ventricular failure should improve. But if you put those patients on peripheral VA ECMO, what will happen is that the blood ejected from the left ventricle will still be poorly oxygenated at the early phase of your ARDS, and you will have a competition of flow with the flow that is being reinfused from the peripheral VA ECMO, and you will have differential oxygenation. So for those patients, probably VV ECMO and venopulmonary artery ECMO at the early phase will be the way to go. While if you have patients with severe and chronic pulmonary hypertension, it's unlikely that veno-venous ECMO alone will be able to support those patients. So once you've confirmed the indication and that you don't have any contraindication, You will do a quick but still thorough assessment of your cardiac function. You will make sure, again, that you don't have any contraindications. You also want to make sure that you do not have any pathologies that may require additional treatments. Those are not contraindication to VA ECMO, but obviously if you have a papillary muscular rupture or a ventricular septal defect, these patients will need additional interventions. And you also want to make sure that there is nothing that could hinder your cannulation. So you have these patients with a thrombus at the SVCRA junction. In and of itself, this is not a contraindication, but this is still something that you want to be aware of before you proceed. For the insertion, the role of the echocardiography will be to avoid these kinds of complication. This is a patient that was placed on VV ECMO, not VA. They told us it was straightforward. I think maybe they meant that they went straight through the heart. And unfortunately, as you can see, there's a significant pericardial effusion and subsequent tamponade. But I also want to emphasize that the fact that you have an echo is not going to prevent this complication if you're not aware of all the steps of the procedures and that you know exactly what to look for. So you can use both transthoracic echo and transesophageal echo. If you're using a transthoracic echo, the views that you're going to use are going to be mainly the subcostal window, and if you're using transesophageal echo, it's going to be more the mid-esophageal views and the view at the vena cava, both inferior vena cava and superior vena cava. As you can see on this view, this is a view at the junction of the gastroesophageal junction, and you can see the venous wire being advanced. And then for the rest of the procedure, we place the wire both in the inferior vena cava and in the superior vena cava. This is probably the safest position for the wire, so that even if you have a very enthusiastic operator that pushes the cannula very high, you're still only in the vein and you're not in the heart, and you may prevent some further complications. For the arterial wire, you also want to make sure that it's in the aorta, and you want to make sure that during the serial dilations you don't have any dissection that may appear. So it looks like this. We have the wire that is placed from the inferior vena cava to the superior vena cava, and you see the cannula being advanced up until the desired position. So on veno-arterial ECMO, there's not a lot of debate of where to place the cannula. The drainage cannula will be at least at the right atrial SVC junction so that you can optimize the drainage, and this is what you see there. So once your patient is on ECMO, the role of echocardiography is not only to look at your ventricular function, but you also want to use it anytime your patient has drainage insufficiency, because it could be that your patient is extremely hypovolemic, it could be a cannula position issue, could also be tamponade and tension pneumothorax. And I really want to emphasize that it's not a good thing to get hyper-focused on the heart. You also want to make sure that you're not missing such findings of a beautiful tension pneumothorax. As I mentioned before, it could be a cannula position. You can see here that the drainage cannula is stuck in the interatrial septum, and that was causing drainage insufficiency every time the patient was coughing. So for the monitoring, you will look at your biventricular size and function, look for signs of recovery, and also assess any pre-existing pathology, and look at your mitral and aortic regurgitation. And one of the most important things on VA ECMO is to also look at signs of left ventricular distension, look at the opening of your aortic valve, and look for intracardiac spontaneous echo contrast. Because we know that we place those patients on VA ECMO because they have cardiac failure, but we also know that we will increase the afterload of the left ventricle. What you see here is you have a pressure volume curve with the baseline curve, and every time you increase your ECMO flows, you can see that the left ventricular and diastolic pressure is increasing, but also your stroke volume is getting smaller and smaller. And what eventually happens is that you have a non-ejecting heart with an aortic valve that is barely opening here, with worsening pulmonary edema due to the increase in left ventricular and diastolic pressure and left atrial pressure. So the first thing is to make sure that you adapt your ECMO flows to the lowest level tolerated that would allow patency of the circuit, tissue perfusion, but also opening of the aortic valve. Unfortunately, that's not always possible, and you may have patients, as these patients here, where you see that you have a non-ejecting left ventricle with an aortic valve that is not opening, significant spontaneous echo contrast within the aortic root, and already a thrombus at the apex of the left ventricle. I am not going to go in the discussion of what is the optimal ways to unload or vent the ventricle. I think there is a talk this afternoon. I think it's track 1. But I think what's important to know is when the echocardiography can help you decide which modality of venting you may be needed. Because, for example, if you're using a microaxial pump as an impeller, this is contraindicated if you have a left ventricular thrombus, because you may suction the thrombus and then re-inject it in the systemic circulation. If you have more than mild aortic regurgitation, you will drain the blood from the left ventricle, re-inject in the left atrium, but then all of that blood will leak back into the left ventricle. And similarly, if you have a ventricular septal defect, you may make a right to left shunt worse by placing an impeller. If you have an intra-aortic balloon pump, similarly, if you have aortic pathology or more than mild aortic regurgitation, that would potentially make it worse. And echocardiography will be crucial for the guidance and the positioning of those devices. Also important, in case you have an intra-aortic balloon pump, to make sure of 2 things: that you intermittently change the frequency of the balloon and look at aortic valve opening. This was a patient who had myocardial infarction, had an intra-aortic balloon pump placed initially. This was not sufficient to support his hemodynamics, so they eventually put him on VA ECMO, and you can see the balloon was still on 1:1. The blood pressure was 93/56, but this patient became increasingly dyspneic, and in fact, the aortic valve was not opening. You can see significant spontaneous echo contrast in the left ventricle, which subsided once we started this patient on inodilators and restarted some inotropic support. So when you have a balloon, do not rely just on the pulse pressure, but make sure that you change the frequency and assess frequently for the opening of the aortic valve. This is another patient who had a non-ejecting left ventricle, and in that case, they decided to place septostomy, so you see the cannula through the septum, and in that case, this allowed to decrease the left atrial pressure, eventually decrease the left ventricular and diastolic pressure, and allow the aortic valve to open. When it comes to the impeller, this is how it looks on an echocardiography. You can see the aortic valve is here, and you have different components of the device, depending on which impeller you're using. So this was an impeller CP. We don't see the teardrop that should be here, but you have, the pigtail. The teardrop is here and the inlet is here. And you want to make sure that the inlet is in the left ventricle and the outlet is in the aorta. The impeller 5.5, for example, doesn't have a pigtail, but you also want to make sure that you're not impinging on the subvalvular apparatus of the mitral valve. Also very important, not all loss of pulsatility equates to venting. This was a case of a patient who was initially on VV ECMO for severe ARDS, was switched to central VA ECMO. Eventually, I will pass the details, can discuss offline about this. And this is the echo initially when the patient was placed on central VA ECMO. A few days after being on VA ECMO, this patient lost their pulsatility. Blood pressure is now 78/75. The ECMO flows were steady at 5.25. Norepinephrine doses also didn't budge, 0.04 mics per kilo per minute. Saturation was 98%. Tidal volumes was 20. This patient was still in severe RDS. Urine output was maintained, creatinine was normal, lactate was normal, liver function test also normal. But when we repeated the echo, what you can see is there's now a significant pericardial effusion. May not meet the criteria of being a large effusion, but took only a few days to accumulate. And I had a bit of a hard time convincing the surgeon that something needed to be done, but you can see that the contractility here was extremely poor with the aortic valve barely opening, and all of this improved as soon as the patient was drained. And one of the reasons was that the left ventricle was no longer filling because of the increased intrapericardial pressure, but also the increased pericardial pressure was compressing the coronary arteries and was causing some degree of myocardial ischemia. My point with this case is to illustrate the fact that when your patient is on VA ECMO, be extremely careful with diagnosis of tamponade, because none of the signs may be present. They may be present when you're on VV ECMO, but you may not have the signs of tissue hypoperfusion and the hemodynamic impact when your patient is on VA ECMO. So the last role of the echo in patients on VA ECMO is for winning. The initial parameters that were described for winning were mainly focused on the left ventricle. So you had the aortic VTI more than 10 centimeters, the left ventricular ejection fraction more than 20 to 25, and the tissue Doppler of more than 6 centimeters per second. Eventually, they realized that integrating the parameters, looking at the right ventricle, were also crucial. And if you have appearance of ventricular interdependence, of worsening ventricular interdependence, that portends a poor prognosis and potentially failure to win from VA ECMO. If you have access to 3D right ventricular ejection fraction, you can use it with a threshold of 25, knowing that this correlates well with your central venous pressure and your fractional area of change. Other markers that you can use are the coupling of the right ventricle to its pulmonary circulation, because the fact that you do not have elevated pulmonary artery pressures may mean two things. It's either that it's normal, or it means that the right ventricle can no longer generate enough pressure to increase your PA pressures. And so in those cases, you can look at marker of coupling of the right ventricular function to the PA circulation. The one with the best sensitivity and specificity in this case is a tricuspid annular S prime divided by your right ventricular systolic pressure, and those perform better than the initial parameters that were described for winning, and you can also assess them at moderate flows. There's also some benefit at looking at the changes of some of those parameters, such as the lateral E prime at the mitral annulus and the tricuspid S prime, meaning you look at baseline ECMO flows and when you decrease the flows, and patients who are liberated from ECMO tend to have a more significant change than other patients. But I think it's also important to realize that it's not just about the echocardiography. Yes, you need to look at all those parameters, but you also want to assess the hemodynamic of your patients, making sure that you don't have a significant increase in your inotropic support to be able to maintain those parameters. Otherwise, you may think that a patient is ready to be decannulated, but not completely. So to summarize, I would say that the role of echocardiography in patients on VA ECMO is from initiation to confirm the appropriate configuration, make sure that you don't have any contraindications, and to guide the procedure. Once your patient is on ECMO, anytime you have drainage insufficiency, you will at some point require an echocardiography, and you will follow your biventricular function, the aortic valve opening when your patient is on VA ECMO, and you will integrate your echocardiographic parameters to decide when your patient is ready to be decannulated. And on this, I thank you for your attention.
Thank you, Dr. Dofle, for the nice talk. I will be delighted to introduce now Dr. Alberto Goffi. He is one of the staff at St. Mike He's also one of my mentors back when I was in Toronto. He's assistant professor at University of Toronto. And he's also the co-director of St. Mike Adult Critical Care International Fellowship Program. If Alberto is talking about something, he will definitely talk about the ultrasound. So he is talking about enhancing patient care with point-of-care ultrasound. The floor is yours.
Thank you, everyone. Good morning. It's a real pleasure to be here. And we are moving away from ECMO. Disclosure is that I will not really discuss about ECMO. I knew that Ghislaine was talking before me. I kept my talk on more general. These are my disclosure. Sorry? This one? The other one? Perfect. As you can see from my disclosure, I gave lectures in the past for ultrasound companies, but more importantly, I'm fully biased. As you can see, my daughter was not even 2 years old, and she was already scanning my wife when she was pregnant with our second son. So truly is that I believe in early use of ultrasound. In the next 20 minutes, what I'm hoping to do, I'm gonna try to focus on the evidence and show a little bit where we are and where we should be on the use of ultrasound in the ICU. Because the question is really is that, do we need this, right? Is that I think is that Ghislaine clearly showed us some excellent cases where ultrasound has an impact in what we do in our ICU. But truly is that, do we need it, right? Is that, do we need point-of-care ultrasound? Is that, do we need an intensivist that's already busy in terms of knowledge and skills to learn another skill and practice another skill when we have a multiple patient unit where, especially in academic centers or in center where we have access to resources, we can ask our friends, cardiologists, radiologists, to do the ultrasound for us. And that's, to me, a key question. Do we need to waste our time, use our time differently? I'm just looking at Margaret there, is spending more time with families and patients. So a few cases to introduce the idea here is that this is a patient I saw a few years ago when I was on rapid response team, where I truly believe that there is a huge role here of point-of-care ultrasound. Is that especially we were calling the psychiatry ward with seizures. She had psychosis, she was admitted with seizures. When I arrived in the psychiatric ward, it was clear that she was not just seizing, she was in shock. And literally in less than 5 minutes, at the bedside in the psychiatric ward, I identify the cause, I started the treatment and some management because of ultrasound. Imagine that they call your patient in shock, your differential is very broad, and if you don't have a tool at the bedside that can clearly identify the dilated inferior vena cava, so telling me a lot of information regarding the shock pathophysiology. But then even in this case, the thrombus in the inferior vena cava and the thrombus in the vein, it would be very difficult to initiate effective treatment. I thrombolized this patient on my way down to the ICU, even before I arrived in the ICU. And I do believe that ultrasound really changed my management and the outcome of this patient in this case. This is a girl that I saw literally last week before flying here. Was admitted under medicine with sepsis, bacteremic, cardiologist, they did this first echo here in the emergency department. No vegetation seen. And I went back to images, it was not visible at the time. 3 days after, this is where we are. I never saw in my entire career such a rapid progression of a vegetation in over 3 days. And this image was obtained by a fellow overnight when the patient that compensated on the ward was brought down. And that clearly led us to a change in our approach, management, consults. This patient went for surgery, and she's doing actually okay back on the ward. And again, sure, we ultimately may have repeated ultrasound, but how many days after? I don't know, to be honest. And then finally, a scenario where I wonder often is that the feasibility of asking my cardiology colleagues, radiology colleagues to come and repeat echo is that this is a patient that was considered unwinnable in the unit. And what I did is that I did a serial ultrasound of the lung and of the heart during the weaning, during the SBT. And I was able to identify the cause of the weaning failure and document clearly the etiology of our failure with the worsening mitral regurgitation, ischemia, and weaning-induced cardiac dysfunction that led to an intervention and ultimately helped the patient to wean from the ventilator. And if you look at the literature, in the past 20 years, there's been a significant shift in the acceptance of this paradigm, right? Is that in 1999, the American Society of Cardiography were saying that laboratory extended sonographers, essentially non-cardiologists, non-sonographers, should be discouraged for using the technique. 2010, well, maybe if you are good trained, you may use it in certain specific scenarios. 2013 is expected. Notice that from discouraged to expected. And this terminology pervaded even our society. And back in 2011, 13 critical care societies globally, they released a statement saying that the basic critical care echocardiography and general critical care ultrasound should be required part of training of every ICU physician. And more recently, multiple people that were here in this conference actually this week, we were involved in this sort of document with the SICM where we try to highlight what should be the basic skills that every one of us should have in the ICU. However, I warn you, right, is that we are all very well aware of the tail of the pulmonary artery catheter and the fact that an amazing tool has been essentially killed in certain area of ICU care because I think is a series of problems. And one problem is that what Mike Kopinski told us on the first day of this conference, the fact that ultrasound, pulmonary artery catheter is a monitor device, is not a treatment. And if the treatment is not effective, or if the decision that comes from the numbers that we are seeing is incorrect, the outcome will not be good. And the other thing is that I show you those three cases, right? Of course, I did those ultrasound, they changed my impact, the patient did it well, and it was very satisfying for me. But is this evidence-based medicine, or is simply visually satisfying medicine? And that's what we need to ask of ourselves. When we are thinking about a diagnostic tool, we have the diagnostic utility, is accurate, is precise, but we also, more importantly, need to ask ourselves, is it useful? Is there any clinical utility? Is it impacting the outcome of our patient? Because again, if ultimately is not changing the outcome of my patient, I'm spending more time, more money for something that I may not need. And if you think about it, the implications are very ramified. There are multiple options and possibilities here. I have a clinical problem. I do my standard chest X-ray, BMP, ECG, whatever you use at the bedside, or even CT scan. And I have my diagnostic hypothesis. Ultrasound can change my diagnostic hypothesis by identifying a different condition, but be careful. May also mislead me. I've seen so many IVC thrombi when they're actually just simple artifact. And people that reacted to this and then thrombolized patients where there was actually no reason to thrombolize. There are situations like my first case where I had a patient with an infectious shock and truly ultrasound led to reduction of my diagnostic uncertainty in a limited care scenario where I had limited access to resources. Even if it was in Toronto, I was on a psychiatric ward in a patient with no IV access. And then once I have the diagnosis, that's the coupling with the treatment. And again, it's a big leap if you think about it. So you need to ask ourselves is that what can we do with ultrasound? And is ultrasound truly changing my outcome and which outcomes is impacting? Well, central line, I think it's easy, right? Is that I don't think any of us, except in emergency, is nowadays doing ultrasound, landmark-guided ultrasound central line cannulations. The literature is quite good on this. I think is that we have good data, suggesting the fact that it's not just improving our first attempt success rate, but it's also reducing complication. This is a Cochrane systematic review from 2015. But this is not a diagnostic test in this case, right? This is a support for a procedure. Diagnostic test, as I discussed, there is a big leap, is that from the result of the test and the performance of the test to the patient outcome. A few examples about conditions that we do routinely carry in ICU, right? Shock and acute respiratory failure. When we're looking at accuracy, okay, so remember that diagnostic utility and clinical utility. Diagnostic utility, I'm talking at the very, very bottom of this sort of use of this test. Well, if you use ultrasound at the point of care, performed by intensivist, it's quite accurate, especially when it comes to differentiation of shock. And again, Ghislaine showed us cases, I showed my case at the beginning. Not just accurate, but also very good at reducing that diagnostic uncertainty. And if you think about that, that's one of the things that characterizes us as intensivists. We embrace uncertainty in what we do because we deal with patients that are undifferentiated, unstable. When we have limited knowledge of the patient, we don't have all the information when we start treating. And that is why I went to critical care, but also what scares me of critical care. The fact that I often do things that they may be very harmful potentially with the patient without controlling all the information. And if I have a tool that is giving me some extra knowledge, well, I'm for it. Respiratory failure, this is a study from Denmark, when what they did is they randomized patient presented emergency department with the acute respiratory failure or dyspnea to standard of care, chest X-ray, ECG, physical exam, and a point-of-care ultrasound-guided algorithmic diagnostic approach. And what they show is that, as you can see here, is that at the 4 hours mark, so 4 hours since admission, patient in the ultrasound group, they had more accurate diagnosis, correct diagnosis of the cause of the dyspnea. And of course, in this specific case, again, is that my supervisor in the fellowship told me that if you know the diagnosis, then you can Google, and maybe now it's ChatGPT in terms of treatment. So more correct treatment order. Recently, the ACP, American College of Physicians, they did a great exercise looking at the literature. And what they show us is that if you use point-of-care ultrasound in patients with dyspnea, in the emergency department, in the ward, in the ICU, you are significantly increasing your diagnostic accuracy. Your standard of care for diagnosis of causes of dyspnea in the early phase is 59 people per 100 standard diagnostic pathways with standard of care. If you add ultrasound, you're increasing to 91 over 100 people. Quite significant. Not just on the ward, the emergency department. As I mentioned, my first case was on rapid response team. And that's where truly I embrace the technology, because it's a scenario where I am in a limited access to resources because of the environment, and where truly is that decision to triage, decision to treatment, it's critical. And this study from France showed that if you integrate the use of point-of-care ultrasound in your rapid response team intervention, you get to diagnosis faster, and your diagnosis is more often correct. So it's great, okay? It's accurate, it's precise, maybe. It's a great performing tool. The problem is that I think, as an Italian, you all agree that Ferrari is an amazing car, but I'm not a Formula One driver. And if you give me a Ferrari, I'm going to have an accident. And the question is, will I win the race if I drive a Ferrari or not. And that's the patient outcome. Study from the Netherlands, actually the multi-center international studies, but the lead authors from Amsterdam, what they look at the next step, right? Okay, the test is accurate, but is it changing what I do? Because if I do a test and then ultimately I don't change what I do, why even doing it? And what they show is that in this large 725 ultrasound performing ultrasound was changing clinical impression in 48% of the situation, leading a 23% diagnostic change impact, and at 39% of the time there was a management that was changed by performance of ultrasound. Again, it's a therapeutic diagnostic impact. Doesn't mean that the response is the right one. Think about the cases that I think I saw a clot, I thrombolized the patient, but the patient didn't have a PE. Okay, so this is still not enough for me. We don't have a lot of evidence, to be honest, but I found a few interesting studies that I think they're giving us some of the initial answers they are looking for. For the one that don't know the MIMIC database, so the Beth Israel in Boston, they, for many years, they've been providing the entire patient data of their outcome, test, perform for research. And I found 3 studies very similar looking at the use of ultrasound, echocardiography specifically, in shock, in septic shock, in respiratory failure, and acute kidney injury. And all the 3 of them very similar from their perspective. They look at the data things, so look at here, 17,000 admissions for sepsis in this case, 6,000 included, and they divided the cohort in patients that have received an echo in the first 24 hours of admission, and patients that they receive an echo after the first 24-hour admission. Not surprisingly, when you look at the original, the balance of the population, if you do an echo in a non-randomized fashion, who are those patients? The sickest one, right? So first of all is that the patient, sorry, it's here I'm thinking I'm covering, but the message here is that the patient that they did an echo in the first 24 hours, they were sicker. And despite that, the sickest patient, they have lowest mortality. Suggesting that maybe there's a signal that using this technology, maybe because it tells you that the patient has a PE or there's a tamponade, something that may actually change the outcome of the patient. For the sake of time, I'm going to be quick on the other 2. ARDS patient, exactly same message. ARDS patient receiving an echo in the first 24 hours since admission, sicker, better outcome. What about acute kidney injury? Same message. Patient receiving an echo in the first 24 hours of their admission at Beth Israel. I have 3 minutes left. I put my own timer for safety. Better outcome. Okay? A group from London, Ontario, and McMaster recently did an excellent job in looking at a systematic review of patients in shock who underwent point-of-care ultrasound and identified 18 RCTs. Less vasopressors, less renal replacement therapy, faster lactate clearance, and less 28-day mortality. And I think this is telling us a strong message. Again, we need more data, but we are going in the right direction. Lung ultrasound, very similar. This is another systematic review recently published. Less time to diagnosis, less time to treatment, increase appropriate treatment, and a signal to an important outcome for us, as for example, as SSU stay. Mortality for lung ultrasound is not actually significant in this study. Okay, the last 2 minutes in terms of what I see the future of point-of-care ultrasound. Well, diagnosis is important, but also monitoring and making decisions regarding treatment of what we do in ICU is important for me, is that using ultrasound as a monitoring device, not just a diagnostic device. This is a near-drowning patient that presented to us with a severe shock and respiratory failure, and a horrible, horrible consolidation. And what I was able to see the lung recruitment. Not measure the lung recruitment, I was able to see it. You can see here is that from a consolidation to a full recruitment of the lung. There are now studies, this is a study published in the pandemic by Guérin Group, the PROSIVA trial first principal investigator, showing that you can use lung ultrasound to assess recruitment. And this is a study published, I think 3 weeks ago, not just recruitment, but now we may be able to see the other side, right, of what we do in mechanical ventilation is the overdistension. And by using speckle tracking, this group from Italy was able to identify changes in alveolar overdistension by observing the changes in this movement of the pleural line with ultrasound using speckle tracking technique. Of course, and I'm finishing here, is there's no way that I'm not going to talk about in this conference without mentioning artificial intelligence. There's a lot of work being done on this. How can we use artificial intelligence? How is it going to change our way of practicing? Well, expert guidance. You don't need to be, maybe in the future, you don't have to spend 2 years with Ghislaine doing a Riseko fellowship, because a lot of the work will be done by algorithm. And there are now studies showing that you can actually have at the bedside an AI system that is telling you, turn the hand, tilt the probe, and effectively improving the quality of image acquisition. You feed the images to the algorithm, and the algorithm does a full echo report for you and interpret the images for you. I'm going to skip this video, but this is a commercially available software that can be used at the bedside. What you can see here is telling the operator how to move the hand, and based on the position of the probe on the chest, helping the nurse, in this case, to acquire excellent quality ultrasound. Finally, it's not just AI, but it's also technology that's evolving. This is an ultrasound. It's a patch. Okay? MIT group 2 years ago published this study, and that's the quality of the images. So think the implication for this is that Johan Goriger in Toronto is looking at the diaphragm, and there's been some discussion during this conference about closed loop ventilation. Imagine where you have a patch, there's an ultrasound, you position it over the diaphragm, and he's constantly monitoring for you the thickness and thickening of the diaphragm, and he's feeding the signal to the ventilator to change the settings of the ventilator to reduce both atrophy or injury for the diaphragm. I will skip the part of ultrasound as a treatment because my time is up. Just sort of closing messages. Well, point-of-care ultrasound is clinician perform. We do it. It's considered now a required part of the training of every ICU physician. There is an established diagnostic utility for what? To use ultrasound when POCUS is not promptly available, comprehensive ultrasound is that in an emergency situation, or where comprehensive ultrasound is not practical, repeating the study over and over multiple times in a day. However, we need more research on patient treatment and clinical outcomes, because I don't think we are there yet. And I think the future of point-of-care ultrasound is bright, because both technology and miniaturization is really helping us in changing the way we are using the technique. I think you all know Eugene Braunwald, one of the most influential cardiologists in history. And a few years ago, it was this editorial where trying to add a fifth pillar to bedside physical examination: inspection, palpation, percussion, auscultation, and insonation. And I truly believe that this is the way to go. Thanks.
Thank you, Alberto. Can we have some chairs up here, please? And can we have the speakers also as well here for 10 minutes of questions, please? Any questions? Oh, yeah. Oh.
Hi, this is Sarah. My question for Ghislaine. Ghislaine, I know you spoke about the utility of echo during cannulation. So my question, like in ECPR setting, which we do, I find sometimes, we working today with the cardiologists and they want to check where the cannula is, which is important, but I feel in the setting of ECPR, the delay of using echo, and we know in this situation, every second or minute count on patient neurological outcome. So what do you think of utility of echo during ECPR situation? Do you think probably more safe, but you don't think it might delay our cannulation strategy and might impact our neurological outcome as it will delay having a flow?
So the first disclaimer is we don't do a lot of ECPR in our center, but I would say it should not delay the procedure. I think in the setting of ECPR, what you want to make sure is, number one, do you have a reversible cause of cardiac arrest that you can address before you actually need to proceed? And the second thing is you want to make sure that you're in the venous system and the arterial system, because when you're doing the procedure under CPR, it's very easy to confuse artery and vein. So then the position of the cannula, I think, is not as important as when you have another situation. I think in that setting is you need to put the cannulas in and be able to support your patient. And if you need to readjust later, you can readjust later. But I don't do a lot of ECPR, so maybe Dr. Pellegrino or Shekhar.
I'm assuming you mean the drainage or the access cannula? Yeah. So, so the critical points, because time is very important, is that the wire is in the femoral vein. It's confirmed at the cavo-atrial junction on subcostal view before the cannula is inserted. Then the cannula is generally inserted all the way from that point. And then you commence flow, and then you can come back and adjust the cannula at that point. But you shouldn't be tracking the cannula insertion under direct guidance generally, because that will slow you down at that point.
Can I just add one thing? I think is that the point that Gisela was making, there are actually data that during CPR, not necessarily the artery is the vessel pulsating. Okay, and so I think it's critical for a guidance to puncture that time to, that's the Cochrane review, right? Is time to effective cannulation, ultrasound make it faster. So if time is your problem, use ultrasound for the cannulation. Then I agree that everything else is that you have time to fix the problem. But getting into the vessel, ultrasound is going to make your life easier and faster, for sure.
And as Dr. Pellegrino mentioned, you can always readjust the position afterwards. You can start your ECMO flow, make sure your patient is supported, and then you can readjust.
There is one more question.
Congrats to all the speaker, amazing talk. One comment for Kiran. Just an opinion about the use of intralipid emulsion for the management of some intoxication. In my experience, I did a lot of mess till I had to change the oxygenator. What's your experience about?
Yep, great question. I think, look, I know where you're coming from. It's a question of, okay, if someone's on extracorporeal support, which is life-saving for the patient, and you're using an intralipid as an antidote or a scavenger, you are at the risk of losing the circuit. That's the fear people have. And look, we've done some studies. We looked at propofol. Propofol is safe. So if you're using propofol in certain toxicities, that's fine. But if you're using intralipid, from what we have seen, we actually did a ex vivo experiment. It doesn't seem to make a big difference, but you have to do what you need to do. So once they're on ECMO, the urgency to give intralipid is no longer there because they're already well supported. But if you ever have to do it, better have a prime circuit ready, in which we always do, in case there is a circuit loss. Does that answer? Thank you.
Thanks for the talk. Just I have a couple of questions. For the cases that you put a VPA, ECMO, I mean, it's unless you're cracking the chest or something, what's your experience about the RP Impella or the Protect U in those scenarios? Wouldn't that be, I mean, Protect U is massive, but the RP Impella, wouldn't that be a little bit less morbid? And the second question is, echo is not always feasible. Echo images, especially after LVADs or stuff, is really difficult images. I'm a cardiologist, I'm an interventional cardiologist, so we like invasive measurements, and there is a lot of shift in SCAI guidelines to go towards these parameter PAPI and the others. What's your guys in general like experience or recommendation in these regards, in regards of using invasive hemodynamics measures rather than echo as a sole measure in assessing the response and when to wean?
There's a lot to unpack in that. If I could start, unfortunately I didn't get enough time to show you some data that raises some concerns about using VPA in the circumstance where you have impaired right ventricular function and increased afterload. And when you do apply VPA in that, if you're not monitoring invasively the pulmonary artery pressures, one of the things that can happen is the afterload goes up. And the actual reason you're using VPA ECMO is to diminish the work done by the right ventricle. In actual fact, the pressure volume area goes up in that circumstance. And I don't think it's well appreciated in ARDS. I think if you are going to use a VPA circuit, then you also have to have a pulmonary artery catheter or some sort of monitoring for the pulmonary artery pressure on a frequent basis. And I think that combination is really difficult to do. You know, in the 25 years I've done VV ECMO, I would say right ventricular failure resulting in a lactatemia or rising pressures during a VV ECMO run has happened once or twice that we've had to do. So I don't know if it's not a well understood phenomena what causes right ventricular failure during VV ECMO. It's prognostic, it's significant, it's been studied, it's in the literature, but I don't think people can tell you exactly what causes it. It might have something to do with the configuration of the ECMO, because it shouldn't have a direct effect. The blood you take out of the venous system is the blood you return to the venous system at the same rate. It shouldn't have a direct effect. I might let others add to the conversation. I think the place of invasive hemodynamic pressure monitoring is important in some circumstances. That's a really good example, the one you just mentioned.
Great question. Yeah, look, I think going to the Impella RP, like, you know, we don't want to take name of any products and we're agnostic to the brands, but in principle, yes, I think Protect is definitely a step forward. The Impella RP, obviously it's transfemoral positioned, so it's very temperamental in terms of positioning, and whenever we used it, it was a nightmare. And often in these patients, we want them to get up and mobilize and not lie in bed. It's sedated with neuromuscular blockers just to keep the cannula in position. So Impella RP they were pioneers. It was a great idea, but then better products probably became available, and then Protect Duo. I share the same concerns Vin has, because probably has seen we've done a study in the mock circulation loop looking at the impact of various afterload and contractility conditions of the right ventricle and what happens. So there is a trap, but I think it's still better than a surgically placed RVAD. Maybe we don't know. Yes. Yes. Absolutely. Yes.
Without mentioning.
Yeah. Have you used it?
I've placed all the above except the like the venous PA because that's surgically placed. I've placed a ProtectU. It's massive. Like really, I had to push. It's a 32 French cannula.
Yes.
It's massive. The RP Impella is way easier. It's still challenging, but more easier. But the point is the comorbidity that comes with the ECMO. You know, even with the arterial cannulation, the distal perfusion, as interventional cardiologists, we hate cut downs. We really, it's like gives us itch to do cut downs. But I'm just talking about the comorbidities that comes with it. RP Impella, to my experience, has the least probably comorbidities that comes with it. But efficacy, again, I haven't used it much because it comes in a certain setup.
Before I go there, one last thing is that absence of oxygenator is a big thing with the RP Impella, and it depends on the drivers. We have excellent surgical backup, so we got access to well-positioned surgical RVAD, which has actually worked very well for us. So there is an institutional kind of bias as well. Yeah.
No problem. Sorry, I'll have to bring the session to a close. I'm welcome to come up and ask our experts these questions at the end as well. But thank you all very much for attending. And just now, time for morning tea. And can the panel stay back for a quick photo? Thank you very much, everyone.